everybody. My name is Pamela Chang. I'm one of the vascular neurologists here at KPLEMC. And today I'm going to be talking to you about our post-thrombolytic care for our stroke patients. So currently, for all of our stroke patients who receive intravenous thrombolysis, they're all getting monitored in an ICU-like setting for 24 hours to, look for signs and symptoms of a symptomatic hemorrhage. But there's not any really supporting data behind this. This protocol was derived from the NIHSS trial that was published back in 1997, and it sort of just carried on for the next, few decades without any supporting evidence. However, recently there's been some studies that have shown that many patients do not actually require an ICU level of care for the full 24 hours, as the majority of hemorrhages actually occur within the first 12 hours post treatment. And hopefully, I can convince you guys of that here today. So this is one study that was published back in 2018 in the Stroke Journal. So it was a study done out of Johns Hopkins. So it was a prospective study from 2004 to 2017. They followed 385 patients, and they found that about 5.5% developed a symptomatic hemorrhage. However, the mean time from the thrombolytic administration to the time that they had their hemorrhage was 8.5 hours, so well below the 12-hour time frame. So this translated into more than 80% of hemorrhages occurring before 12 hours, and only about 1% of patients had a symptomatic hemorrhage after the 12 hours. Interestingly, the average NIH was 11.9, so quite high. And they did find that the higher the NIH, the more likely patients were to have a symptomatic hemorrhage. They also found that combination therapy, so patients that received both intravenous thrombolysis as well as endovascular therapy, they were also associated with an increased risk of hemorrhage. This is another prospective study. It followed patients given both IVTPA and or thrombectomy between 2016 and 2018. They found that only 3% of patients had a decline within the 12 to 24-hour period. And of those 3%, 4 out of the 5 actually did show signs and symptoms of exam fluctuations in the preceding hours. And so it was almost like we, had some clues or some evidence that these patients, may deteriorate later on. They also found that patients with more severe strokes and higher NIH were more likely to experience a neurological deterioration. And again, similarly to the last trial, they found that patients who had combination therapy were more likely to have a decline versus those patients that just receive intravenous thrombolysis. So this was the Optimus study, also done at a Johns Hopkins. It was a phase 2 study, clinical trial. So what they did was they enrolled 35 patients post IV TPA only. So they excluded patients that received thrombectomy. And they only enrolled patients who had an NIH of less than 10. And here was their proposed monitoring protocol. So for the first 2 hours, basically everything was the same. These patients were monitored every 15 minutes for the first 2 hours. After that, these patients were then downgraded to a stroke unit with a nurse-patient ratio of 1 to 3. And then upon admission to the stroke unit, they did vitals and neuro assessments Q1 times 1 hour, then Q2 times 8, and then Q4 until 24 hours post-treatment. And what they actually found was none of the 35 patients required transfer back to the intensive care unit. So the authors concluded that this was feasible and safe. And currently, there's actually a phase 3 study that's being conducted where they're planning to enroll over 7,000 patients. It should be published. The study is going to be completed in 2023. So hopefully be published maybe a year or so after that. But here are the take-home messages. So remember, we discussed that combination therapy is going to have the higher risk. And so patients that are just getting IVTPA or IVTMK alone have a lower risk of symptomatic hemorrhage. There's a very low risk of symptomatic hemorrhage between the 12 to 24-hour period for all patients, but even lower if those patients have an NIH of less than 10. And nearly all patients who did have a decline between the 12 to 24-hour period did show signs of neurological fluctuation from the 0 to 12-hour period. So here is our proposed algorithm. So we'll just focus on this box here. So this is just going to be patients who have an NIH of 6 or less and not on any IV drips. So for the first 12 hours, these patients are going to be monitored in the ICU, standard neurological assessments, vital signs, and standard nurse to patient ratio of 1 to 1. After the 12 hours, so after the high risk period, between the 12 to 24 hours, these patients will then get downgraded to our telemetry stroke unit. There'll be a one-time complex neuro and GCS evaluation. And then after that, the proposal is that we'll do NIH SS Q2 hours for 12 hours, and then vitals will be Q4 times 12 hours as well. So this is just a side-by-side comparison, kind of touches on things that we've already talked about. So for the first 2 hours, an optimist and our proposed algorithm here at LAMC, it's going to be the same as what the standard is currently, which is every 15 minutes for the first 2 hours. So an optimist, after 2 hours, they did downgrade the patients to telemetry for the remainder 22 hours. They had a 1-to-3 nurse to patient ratio, and here are their neurochecks and vital signs that we already discussed previously. So for us, because we've already sort of hinted that 0 to 12 hours is the high risk period, we're actually going to keep all of our patients in the ICU, no matter what their NIH is, for the full 12 hours. And they'll still have a 1-to-1 nurse to patient ratio. So after the 12-hour period, again, this is the low risk time period, especially for an NIH of less than 10. We're using an NIH of less than 6 to be even more conservative. We'll be downgrading our patients to telemetry. There'll be a 1-to-4 nurse to patient ratio. And again, the NIH is going to be Q2 times 12 hours, and then vitals will be Q4 times 12 hours. So benefits, so obviously, being in the intensive care unit is costly. We take up a lot of resources, hospital beds, staffing. And so the hope is, these patients that, probably don't need ICU level of care will be able to open up more resources and hospital beds for patients that are more critically ill. Also, we know that ICU delirium is a real thing. And so transferring patients out of the ICU earlier may prevent these known ICU complications, which can allow for a faster transition towards home and rehab. And then just some other points. So again, we're not including patients who have any need for IV drips or IV pushes of blood pressure medications. These patients are going to be staying in the ICU for the full 24 hours. Any patients who show signs of exam fluctuations or even early neurological decline, those patients are going to be staying in the ICU for the full 24 hours. Any combination therapy, we're not including those patients in this algorithm. And then just any patients in general who may not fit any of these criteria, but the stroke team or ICU team feels like these patients may have a higher bleeding risk, then it's okay for those patients to also stay in the ICU for the full 24 hours. So that's all I have for you guys. I'm sure if you guys have questions, let Lorena know, and she can relay that to us. Thank you for your time, and yeah, let us know if you have any questions. Thank you, everybody.